Okay. So I know I had kind of gone through these picture slides. Not every, and let me just reiterate this, not every horse do they do what's called rope assisted recovery. Um, but the benefit is just to give, to pull on the horse as they're trying to stand on their own. It just helps give them leverage. So hopefully they don't fall. They do a tail tie on the back, and then they tie a rope to the halter. And usually they tie these when the horse is very asleep. Um, Usually someone sits with the horse initially, because on recovery, you still want to look at their respiratory rate, look at their color, look at their eyes. When they start showing signs of recovery, it's when people usually, when they start paddling their limbs, if they start blinking excessively, if they start trying to move their head, usually people then leave the room. And most recovery stalls, like I said, they have this door open. At Purdue, we had windows um, that you could, so you can stand outside and still observe respiration and movement. Uh, that's about the only thing you can do. And when they're awake, you would then go in and you can remove the ties. And then if you are in with a horse, the best way to try and keep them calm, you don't want to be by their hooves, you don't want to be by their legs, but if you put your knee on the back of their neck and you hold the halter, like lift their head, they can't throw their head and neck, and that's how they stand. So that is some control. Um, the other thing on recovery that you may do is, like I showed in that video with the pool yesterday, is do the nasopharyngeal tube. And the difference is, I talked about nasotracheal intubation, which is a much longer tube and it goes to the trachea. This tube is just going to the back of the pharynx. It's not going to the trachea, and it is only to administer oxygen. So if you had a horse that had difficulty breathing during anesthesia, if you had a horse that had a lot of nasal discharge, because remember, they're obligate nasal breathers, and once you remove their orotracheal tube, and once they start chewing, you have to pull that tube. So if you had nasal discharge, if you had a horse difficulty breathing, if you needed to do that demand valve that I showed you yesterday, that's kind of a way to give a horse oxygen, and it's kind of like a little flush valve attached to the endotracheal tube. Uh, you can do that with a nasopharyngeal tube, and this tube can stay in much longer because, again, you're not going through the oral cavity. You're just going through the nose. So this horse can be licking and chewing. Now, eventually, they're probably going to throw their head. They might try to paw at it because they feel like something's in their nose, so it can't necessarily stay in forever, but you can keep it in to give the horse a way to breathe. And this, in this horse, you don't always have to hook it up to that oxygen valve. I think, like I said, the reason they did that in the horse in the pool was the weight of the water and the weight of the horse being in that raft. It's going to be hard for them to expand their chest. So this way, that demand valve can kind of keep the lungs inflated. This horse may just need an open airway, not necessarily oxygen, just to give them a way to breathe. So that is an option. So on recovery, normally you always stay by the head. You don't want to be by the butt. You don't want to be in front of the legs, because if they paddle and kick, but the best thing you can do is watch their respirations, make sure. And the biggest thing that I've stressed with you guys in any animal is respiratory character. What is the character of breathing? It should be a nice short inhalation, a longer exhalation, than a pause. That's that IE ratio. And it should be a fairly normal respiratory rate. Obviously, when they're recovering, the respiratory rate's probably going to increase as they come out of anesthesia. Their pulse, what's really important is knowing you're probably going to use facial pulses when you're recovering them, because you don't want to be your hand over their chest, because if they roll, and you can't be in front of their chest to feel their heart. And so you're probably not going to be using a stethoscope, and don't you're not going to feel anything in the back legs or in the femur area. You can feel that dorsal pedal pulse, but in a recovering horse, you don't want to be by their back legs. So I use that transverse facial a lot, which goes right under their eye, the facial artery, which is right under the mandible, right under the curve of their jaw. And you just put your finger there and you can count a pulse. You know, ideally you would be listening to them, but it's just a little too dangerous to be over a horse that's recovering in those areas. So you have to think about safety. You know, the eye, when the eye is relaxed, and their eye sometimes rolls a little bit, but not as much as a dog, you can monitor eye movement. And if it's trying to stand too soon, you always want to be prepared to extubate. If the tube is tied to the halter, make sure before that horse is light, make sure you know how to get that tie off, because some of them are taped. You might just have scissors in your pocket so you can cut it and pull the tube. And the big thing that we're looking for is nystagmus and paddling of limbs. Those are two indications. The more nystagmus and paddling they have at the same time is an indicator that they're probably going to try to stand or try to wake up too soon. So if you see rapid nystagmus and paddling, you may need to give a sedative like xylazine or ACE. Now, paddling and nystagmus aren't really signs of pain because, again, ACE promazine is just a sedative. It has no analgesic properties. But we've used ACE in dogs. You know, at VCA, sometimes they wake up rough. They are on a CRI. They've had morphine. We know they have pain meds on board. Sometimes we'll give them what we call a hub of ACE. We draw up ACE in a syringe, and there's a technique. You draw up ACE and you squirt it all back in the bottle. You kind of wash the syringe, and the hub has a little bit of ACE. And then we draw up saline, and then you give that. Now, we've done that in dogs. It's not a calculated dose. It's literally called, sometimes the doctor says, give them a hub of ACE. And that's what that means. You're kind of washing the syringe with ACE promazine, and then you draw up saline in the syringe so that you can inject it. And it's a very low dose. And sometimes that's enough to chill them out, just a little sedative. And you, like I said, if you feel like the horse is controllable, people will try to put the knee on the neck and hold the head off the floor. I mean, their head is very large and pretty heavy. So holding the halter up, knee on the neck, prevents them from throwing themselves up into the air. And again, for extubation, you should see chewing, limb movement, tail movement, swallowing. You want to make sure you also deflate the cuff. So you have to have that 60 ml syringe with you, and then you just pull it, you know, quickly pull it out, and then make sure that there is no change. I mean, their respiratory rate may go up after you extubate them because they're lighter, but the big thing I look for is, are they having a harder time breathing now that the tube is out? And how do I know my patient has a harder time breathing? That ratio, there's more effort, there's more inspiratory effort, and then check their nasal cavity to make sure there's no obstruction, there's no excessive nasal discharge. You know, they're going to flare their nostrils when they breathe, but we're looking for excess flaring, a lot of abdominal effort, things like that. And normally, if you have a good recovery, which that very first video, you know, that horse, you know, they're extubated, and that horse kind of rolled up and stayed sternal on their own. And they should be able to do that. And after a few minutes of kind of being in sternal, they stand in one try. They kind of stand up, and then they might wobble a little bit, but they're able to hold themselves up. And then, you know, this is the stage where you may do that rope-assisted recovery. It's usually, you know, it could be a clinic policy. It could be they deem that horse might need help. The ones we worry about is if the complicated recoveries, when they try to stand too soon and they may need some sedation, they may need more analgesia. I'm not saying they're not going to wake up painful. There's a there is a chance they're going to wake up painful, but if you start to see the nystagmus, and a perfect question is, how do I know a horse is trying to wake up too soon? The rapid nystagmus, the paddling, tails, twitching, uh, things like that. And the big thing we worry about is a catastrophic event, a fractured bone. I mean, the problem in horses is you can do a surgical repair to a limb. It's not completely unheard of. It just doesn't usually work very well, unfortunately. So typically what happens is when you try to recover them, um, if they break, and it depends on what bone they break, because horses don't stay laying down. They have to be standing all the time. There's a lot of weight on the limb. So it does make surgical repair. And some horses will have to be euthanized if they break a leg. And it's just a common consequence. So, that's something that you want to try to prevent at all costs. Now, when we look at, returning the horse to the stall, normally when they can walk and they've stood and maybe they've turned around in a recovery stall, now a lot of this is going to be doctor and case dependent, but normally you put on what's called a basket muzzle and let them drink water. And the reason, like I said, they're going to forage through their bedding and potentially try to get some feed that maybe fell in the stall. And they can, have water, and then probably after that 3-hour mark, they can go ahead and start eating. And again, there could be a special case, but normally you want their GI tract moving and you want them eating. And obviously, a happy horse, if they're comfortable, they're going to eat, they're going to move around. So we're going to want to give them the chance to do that. Now, I've told you the things to watch for that are post-op complications or post-anesthetic complications. One thing that we worry about now, neuropathy is where you have injury to a nerve. And if there was pressure, especially the facial nerve, if a horse is in lateral, a lot of times they'll take the horse's regular halter off, and the hospital has padded halters, and sometimes we just take gauze and wrap it around the halter and vet wrap to keep it padded. You can buy halters that have fleece or padding on the inside, because when a horse's bones are laying on a halter, buckles and things can put pressure on facial nerves. So you want to look for any eyelid drooping, ear drooping, lip drooping. That would tell you that there's some facial neuropathy. Now, it can return to normal. The problem is it's unpredictable. I've told you guys in anatomy, injury to nerves don't follow a healing timeline like bone heal. So it could just be for that day. It could be for a few days, but we do want to do everything we can to make sure the head is well padded, make sure there's no buckles on the halter that are pushing on the horse and putting too much pressure. Now, radial nerve is the nerve that controls the radius, which is, if you go humerus, radius, ulna, so that's the distal forelimb, so that's the lower limb. But if they have radial nerve paralysis, maybe the hocks were not put on. Yeah. And, that's the thing, Madison, is like, sometimes these nerves, depending on how severe the injury is, we can't predict when it's going to come back. So, if you have a horse that can't extend their forelimb, so if they're starting to walk, they might drop a limb. So they might be limping. They may not fully extend it when they're walking. So that could be, again, the hobbles weren't put on, or the leg was stretched when it was restrained, or if the horse was in lateral, if it was inadequately padded. Remember, I said if a horse is in lateral, it's a scissor, either, one or the other, but typically the down limb is pulled forward. And then if the horse is in BD, normally the limbs are relaxed. We don't typically tie them up and stretch them. So they're typically in a more relaxed, so we don't put that excessive pressure. And then when we look for myopathy, that's the muscle. And and this happens from inadequate padding, I told you, and also inadequate perfusion. If there was perfusion or blood, that's actually blood getting to the muscles, oxygenated blood, and their muscles would feel hard or swollen. And sometimes this is the one they called tying up, if a horse is tying up. And they may walk very stiff. So they may kind of have a stiff gait. And then another thing to look for is colic, because if a horse, every anesthesia slows everything down, and it can slow down the digestive tract, and that can cause, and there's lots of reasons for colic that I told you. Ileus colic, or when the intestines slow down or almost stop, it allows a buildup of gas, and that buildup of gas pain is what can make them feel painful. So how do we know a horse is going into colic? Well, you might see them rolling. Now, yes, some horses roll on their back, they feel itchy, but if they're also kicking or biting at their abdomen. Now, you would listen for gut sounds. Do we hear gut movement? But I can't observe that from the outside. I want to know, if you were walking by a stall, how do you know a horse is having colic? And that's usually, you look at their behavior. Maybe they aren't eating. That could also be, you notice that you've put in food and they're not eating it, but it's really the rolling, kicking, biting at the abdomen are the classic signs that a horse is experiencing colic. And obviously, I don't want to see like, oh, listen to the abdomen. Well, once you see those signs, then you're going to go in and listen to the abdomen, but something has to trigger you just from observation. They may look, sometimes people say, what about a swollen belly? I mean, a horse has a very large belly anyway, but you could potentially say they look kind of bloated, but I would say that's kind of hard to notice, because they just have a regular, kind of a regularly large abdomen anyway. So these are big things to look for. Let me go back to something for a second. Okay, so what I think I want to do for this test, because I know I only have like 10 more minutes, let me review things on this PowerPoint for 10 minutes. I've done this with you guys before. Why don't tomorrow too, we have kind of a review in Zoom, and then I would open the test at the end of class and probably keep it open till the start of the next day's class. That way I don't lose a lecture period, but I can get in more review. Does anyone have an objection to that? It would be open from like 9 a.m. tomorrow till like, I'll say like maybe 7:30 a.m. I can do days of the week, Wednesday, or no, we'd be open, today's Tuesday, tomorrow's Wednesday, till Thursday. And then Thursday we would start bovine. Okay, we'll do that. So let me just talk about a few things that I want to stress, because I didn't want to, because I've tried to, I always try to say, let's talk about monitoring, but when we talk about species anesthesia, physiologically, which is internal, what is different about their physiology, that makes them challenging for anesthesia. And the number one thing I think of physiologically is that they're going to have a hard time ventilating. And this is why they're put on mechanical ventilation. And I've not gone in depth about ventilators because it's really an advanced technique. And I would never hire a new grad and be like, hey, new grad, go put that animal on a ventilator. You would get advanced training if your clinic is going to work with ventilators. And so, but mechanical ventilation basically takes over breathing. And so, you know, they're not even going to wait for a horse to develop hypoventilation. Like when you guys work with dogs and cats to some degree, when they hypoventilate, you can bag them. I've told you guys, if your CO2 is creeping up, you have to increase ventilation. You got to close the pop off and bag the patient. And again, that's just challenging in a horse because the bag is so large. You can't barely do it with your arms, and you'd have to be doing it quite a bit. So they just go ahead and so there's an adapter that goes from the ventilator and it goes where the bag would be, where you guys put the rebreathing bag on the machine. You literally take that off and hook up the ventilator, and the ventilator acts like a bag. It's just being squeezed manually. And what it does is I always set the ventilator a little bit higher than their normal respiratory rate to kind of take over breathing, because I've had some animals get light and breathe in between the ventilator. But the whole need for ventilation is because they naturally hypoventilate due to their large abdomen and putting pressure on their diaphragm. So again, it's always, I mean, a horse in lateral is probably going to be ventilated too. It's not just if they're in VD or dorsal recumbency. It's really going to be when they're under general anesthesia. And so, but the big way that we monitor this is what is an indicator of hypoventilation? End-tidal CO2. And that's what you're going to be monitoring. And normal, it's still the same: dog, cat, pig, horse, cow, rabbit, whatever you're monitoring, normal CO2 is about 35 to 45. And again, when CO2 goes up, the only way you get rid of CO2 is you breathe more. So common sense would say, if you have too high of a CO2, they're not getting rid of it effectively. So that's when we assist ventilation, and a horse is going to need that a lot more. And your goal, when you learn how to use ventilators, you can adjust like volume, pressure, and rate. I sometimes fiddle with the dial till I find the CO2 I like. So I can adjust the rate, and I can adjust the depth of ventilation based on my CO2 reading. And then hypotension or blood pressure is, we're really concerned because it can contribute to myopathy. So if you battle blood pressure during anesthesia, there's a higher likelihood that your horse is going to have myopathy or potential for myopathy. And some of that is padding too. So padding helps. But remember, your mean blood pressure in a horse needs to be greater. And I don't want people, you know, I know you remember in school the alligator, which way it's going. You want it to be greater than 70. In dogs and cats, I say as long as your mean is above 60, it means you have adequate perfusion to the kidneys. And if you have adequate perfusion to the kidneys, you should have adequate perfusion to the muscles. But what happens when blood pressure starts to fall? When your mean starts to go in any animal, if it starts to go 70, 60, 50, 40, what happens to blood flow?
You get decreased perfusion.
You get decreased perfusion. The body's kind of like, okay, I can't get blood everywhere. So the organs it prioritizes, brain, heart, lungs, and it sends blood to the core. So if you take blood flow from the animal, or for what I call the periphery, and you send it to the core, then what happens is, first of all, you're not getting blood flow to the kidneys, so they're not getting oxygenated blood. You're probably not getting blood flow to the muscles or to the peripheral tissues. It sends it to the core. So that's the consequence, is because, first of all, kidneys make urine continuously, and that's how they filter toxins. So if you don't have blood going to the kidneys, how is it getting filtered? There's still toxins in the blood, so there's no filtration, and the kidney's not getting oxygenated blood. So we don't want to cause damage to the kidneys. So that's the consequence of, and in a horse, I still worry about the kidneys, but I'm also worried about this myopathy and affecting their muscles on recovery. So that's another reason, but you want to keep it above 70, not 60. And that hypoxemia, let me stress the difference in the terms here. I'm going to type it so that you make sure that you understand the difference, because we haven't talked about this. Wait, where's my chat? There I am. Whoop. Sorry, course trying to type equals. Okay, so if you think it's supposed to be, well, I know, and it's supposed to be great. Well, I'm sorry. What the PowerPoint is trying to show you is, if you have hypotension if it's less than 70, and you have hypoxemia if it's less than 80. That's what the PowerPoint's saying. Yeah, so no, I'm glad you clarified that, because I don't want anybody to think that. So they're saying, what's hypotension in a horse classified if it's lower than 70? So I'm telling you, you want it to be higher than that. No, that's a good point, because that's confusing. Hypoxemia is classified as a PA2 of less than 80. So you want it to be greater. But what I don't want you guys to get confused of is what I just typed up here in the chat. If you remember, PA is partial pressure, and that's oxygen dissolved in plasma. If you remember, PaO2 tells you how much oxygen is dissolved in plasma of arterial blood. But when you guys put the probe on the tongue, you're doing what's called a pulse oximeter, and you are estimating oxygen saturation of hemoglobin. So those tests are they're monitoring the same condition. And SpO2 is telling you, do you have perfusion of oxygen? And a PaO2 is telling you, do you have enough oxygen in the blood? But they're measuring it two different ways. So I don't want you to see 80 in this PowerPoint and go, well, Landeros told me it should be higher than 95. That's a different number. And most of you guys, I'd say almost all of you, are just going to be working with pulse oximeters in practice. If you go into research, equine medicine, or an advanced surgical practice, you will sometimes do blood gases in your patients. And if you measure, so if you take a sample from an arterial sample, that will give you PaO2. But that's the only way you can get a PA2 number. There's no monitor, no electric monitor or something you hook up that gives you a PaO2. So that number comes from a blood gas, and SpO2 comes from a probe. So really 95 to 100 is considered normal pulse oximeter. And if you remember back, I made you guys that little chart, which you all should have day one of surgery rotation, especially if you're the anesthetist day one, is that kind of pulse ox troubleshooting chart. But I told you on there, 90 to 95 is slight hypoxemia, and then 90 to 85 is getting to be a pretty serious hypoxemia, and you absolutely don't want it below 85 on a pulse ox. But remember, since you guys are getting to the point this needs to become practical knowledge, there's lots of reasons a pulse ox probe fails. It falls off the tongue, it's dirty, it's in a bad location, the tongue is dry, so I gave you all, for me, my general rule of thumb when I do anesthesia is if I clean it and move it to a couple different locations and I keep getting the same reading, I tend to believe it more. Because I've had animals getting crappy pulse oximeter readings and their gums look pretty decent. Their tongue looks pretty decent. They don't show true cyanosis until they're getting close to that 85% mark. So an animal can become hypoxemic without looking like it clinically in the tissues. So that's why you have to pay attention to that probe. And if I had a dime for every person I've worked with that I don't consider very good, and some of them go, oh, it's just the probe. Oh, it's just the probe. Oh, have you checked it? Or you just don't like the reading and you don't want to believe it. There's a difference. So use my chart. So I will stop there. I wanted to explain those values. We'll go through. So tomorrow morning at 8, we will Zoom review. We'll kind of go through the homework, although I've probably gone through a lot of the questions. And then any questions, if you guys want to go into your old tests and look at stuff from, the old material, you can definitely do that, but it would be open after we review. And I will put this video up when I get back today. Are there any questions?